The perioperative care of patients with diabetes has for many years been known to be not as good as it could be. And a number of recommendations have been written by different groups about the care of perioperative diabetes. But despite these recommendations, it's been felt that that care is still poor and can be improved. Care of diabetes is complex and it crosses multiple specialties. But if the care of diabetes is good, then there are studies in the past that have shown the outcomes for patients are much better. And that's why it's really important that we get the care throughout the pathway really good to result in better outcomes for patients with diabetes. The main findings of the study were that the care of patients with diabetes in the perioperative period could be improved because there was a lot of disjointed care between various specialties. And despite specialty recommendations, this has not been joined up. And therefore, the main recommendation that we've made is that the Academy of Medical Royal Colleges should provide a national policy with standards for treating these patients. So a number of things we found as part of the study, including the lack of a perioperative diabetes lead, were one of the things that we thought were important. For example, 28% of hospitals did have a perioperative diabetes lead. That means the majority did not. In addition, 21% of hospitals didn't have a policy for emergency prioritization of patients with diabetes. And this was thought to be an important factor which could result in delays and poorer treatment for patients with diabetes. So we recommend that every hospital should have a clinical lead for perioperative diabetes to ensure that patients with diabetes are optimized prior to surgery, to ensure patients are prioritized both as an elective patient and as an emergency list, to ensure that patients have referral to the diabetes multidisciplinary team at appropriate times in their pathway, to assess them for risk of surgery and risk of a poor outcome, to ensure that they get good control of their diabetes, including when to start the variable rate insulin infusion, and to audit starvation periods so that patients are not having prolonged starvation prior to surgery, as this increases the risk of them needing a variable rate insulin infusion. In addition to this, they should be involved in monitoring discharge planning for patients with diabetes, as this was found to be another area which could be improved. The patient's current diabetes control is really important when patients come in for a surgical operation, and knowing about that control and knowing what's been happening to them in the community is really important. And that's why we assessed the quality of referrals into hospital from general practitioners. In the study, 57% of patients were referred by a general practitioner for their elective care. In 41% of patients with diabetes, there was no information whatsoever about the diabetes in the referral letter, and 42% of them had not had an HbA1c within the last 3 months as recommended by current guidelines. So the information in these referral letters was insufficient, to give the correct information to the hospital to make decisions about priority and the care that they're going to receive. So we've recommended that there should be a standardised referral process for patients with diabetes, which includes as a minimum their HbA1c levels within the last 3 months, what control they have of their comorbidities and what treatment they're having for that, a list of the current medication, the body mass index, their EGFR, and a perioperative risk rating to risk assess the patient if they're coming in for elective surgery.
The next recommendation of this report was to ensure that patients with diabetes undergoing surgery are closely monitored and their glucose levels managed accordingly. Glucose monitoring should be included at sign-in and sign-out stages of the surgical safety checklist, in anesthetic charts, in theatre recovery, and in early warning scoring systems. It was also recommended to have system markers and alerts to raise awareness of glucose levels, for example, by tagging electronic medical records or using patient passport or specific stickers if paper-based case notes were being used. The evidence underlying this recommendation included the fact that about 46% of patients did not have capillary glucose recorded intraoperatively. Some of these patients, of course, might have had a shorter procedure, but if you recall, we had excluded all minor procedures, and therefore it was very likely that majority of these patients should have had at least one capillary blood glucose recording. Similarly, we found that in the recovery area, about 13.8% of patients had not had their capillary blood glucose assessed again. About a fifth of patients were thought to not have appropriate post-operative blood glucose monitoring by the case reviewers. While the surgical safety checklist was very prevalent in its use, 97% of patients had one, it was found that diabetes was not mentioned in 30% of these patients. If diabetes was mentioned in the surgical safety checklist, it was more likely that capillary blood glucose measurements would be recorded. And the difference was between almost 60% and 49% during the operation. Including diabetes in the surgical safety checklist was associated with more appropriate management of diabetes in the theatre recovery area, where the difference was 84.3% if it was mentioned, compared to only 63.7% in those that was not mentioned. All services looking after patients with diabetes should ensure safe handover of patients with diabetes from theatre recovery to wards. Almost 60% of patients did not have a clear plan for management of their diabetes on the day of surgery. 12.5% of patients did not have diabetes medications documented on the day of surgery. The post-operative care, in their opinion of case reviewers, was not appropriate in only 3.8% of patients. However, diabetes follow-up was not organized in 16.6% of patients where appropriate staff should have been contacted. What was found was early involvement of a diabetes specialist nurse would have been beneficial in majority of these patients, in the opinion of case reviewers. Similarly, discharge arrangements were not considered adequate in a fifth of patients by case reviewers. So of the 13 recommendations that were made in this report, one of the other important recommendations was to prioritize patients with diabetes on the operating list to avoid these patients having to undergo prolonged starvation. This also supports guidelines provided by the Joint British Diabetes Society, and prioritization of patients with diabetes on operating lists should be subject to a local audit and results acted upon. This recommendation is based on a finding by case reviewers that almost 20% of patients were not scheduled appropriately for the surgery, either them being first on the list of the day or first on the afternoon list for that day. The final chapter of this report deals with the overall quality of care as assessed by case reviewers at the end of each set of case notes. We also looked at the same information in the context of care of patients with type 1 versus type 2 diabetes. And what we found was that fewer patients in the study with type 1 diabetes received good care, which was about 28.1%, compared to 35.5% patients with type 2 diabetes.
If you're watching this video, how good do you think the care is in your hospital for those patients with diabetes? What are you going to do about improving that care, as we've shown deficiencies in the care in hospitals across the country, and we think that needs improving? We want you to take this report away to your organisation and make an impact by auditing the outcomes of their own care and making improvements for patients with diabetes.